Hello, everyone. Thank you so much for joining us on, depending on where you are, what may be a very snowy day indeed. My name is Lisa Simon, and I'm a physician and dentist at the Harvard School of Dental Medicine and Brigham and Women's Hospital. And I'm so delighted to join you all today and to introduce our group of esteemed panelists discussing COVID-19 in both the primary care and medical settings and what we've learned. First, I'll introduce Dean Jane Barrow, who is the Associate Dean for Global and Community Health and the Executive Director of the Initiative to Integrate Oral Health in Medicine. Her work focuses on building the evidence base to demonstrate the value of oral health in care delivery and financing systems. Also joining us today is Dr. Ateev Mehrotra, an associate professor at Harvard Medical School in the Department of Healthcare Policy and also a physician at Beth Israel Deaconess Medical Center, who's done research on a great deal of delivery innovations, including telemedicine and impact on quality and access. Dr. Russ Phillips is the director of the Center for Primary Care and the William Applebaum Professor of Medicine and Professor of Global Health and Social Medicine at Harvard Medical School, and is a general internist at Beth Israel Deaconess Medical Center. And lastly, Dr. Marko Vujicic is the chief economist and vice president of the Health Policy Institute at the American Dental Association. And he has published extensively on health policy challenges and oral health workforce. To start, we're going to have each panelist share, using PowerPoint slides, a few of the facts about the pandemic that through their work they found most surprising and most interesting. And then we'll have what I anticipate to be a really free-spirited and interesting discussion. Lastly, we'll end with a Q&A session. So for those of you who are in attendance, please use the Q&A function found at the bottom of your Zoom screen to enter questions, and feel free to do so throughout the webinar. And I'll try to get to them as I moderate the discussion, and also at the end, I'll make sure that we address them as well. So to start, Jane, we'll have you share a little bit about what you've learned in the context of an academic dental institution, and I will be sharing the slides.
Thank you, Lisa. As you could imagine, we've all done a lot of pivoting, and in academia, with three different areas of focus, it was quite impressive to me how quickly our school and all of our colleagues at other schools around the world were able to pivot and change the way they engage in teaching, research, and clinical care. I don't typically think of academia as being particularly nimble, but it was really amazing to see how quickly we all adapted. In the middle of March, in the course of a couple of days, we all know the world changed, and we went from teaching in person to virtual classrooms. All of our didactic teaching since March has been virtual and will continue to be virtual through the end of the academic year. Our clinical activities were suspended. We front-loaded a lot of didactic programming with the hope that in second semester we would be able to spend more time in the clinic, and it's been going amazingly well. I'm so impressed by what the faculty have been able to do. Research, suddenly everybody is talking about COVID-19, looking at the basic science, the virology, implications for clinical practice. We've had a lot of people spending time thinking about patient flow, operations, negative air pressure, how do we change things, how do we ensure that everything is safe for patients, faculty, and staff, and a lot of health services research underway, trying to understand what this means in terms of job loss, insurance, types of care that will be delivered, and how we prioritize and allocate resources. In our clinic, like many others, we were closed to all but emergency care beginning in the middle of March. In July, we began to slowly reopen. Telemedicine was very important for us. The use of telemedicine really skyrocketed for us and many others, and I'm sure Marko is going to talk about that a little bit. We used to use telemedicine only for on-call situations, but it became very routine. We prioritized urgent care and tried to deal with non-urgent care through medical management. We redeployed some of our workforce. Many of our GPR, our general practice residents, were deployed in other parts of the hospital. Our dental assistants and others were able to help in different areas around the university engaging in COVID testing. So it was really nice to be able to see our dental workforce helping in other parts of the healthcare arena, helping out with this pandemic and backing up their health colleagues. We have begun to ramp up, as I was saying. In July, we opened at about 25% capacity. We really needed to think a lot about how we re-engineered our space. We're now at about 75% occupancy. Part of that is just due to the way we're set up. Part of that is due to choices about taking 1 hour appointments at a time to allow for procedure and thorough room cleaning in between patients. And we did initially prioritize patients who are in mid-treatment plan, but now we are welcoming new patients, hygiene patients, and patients who are more complex as well. And I'm happy to say that we think that our students will be able to complete all of their clinical requirements in time to graduate. So pretty amazing changes in activity in a very short period of time. Lisa, maybe we could go to the next slide. This is a slide from a paper that Dr. Sung Choi, Lisa, and I worked on trying to understand what changes in insurance and employment might mean in terms of access to dental care for the overall population. And you can see a big shift in the green, which is employer-sponsored dental insurance. We were predicting that that would drop off based on the significant job losses that we were observing between March and May, and unemployment increased about 8.4%. 16 million people lost their jobs. And we anticipate that many of these, about 45%, would shift onto Medicaid, and about 47% of those would become uninsured individuals. So that clearly has significant implications, not only for dental care, but for all of us who are in that arena of healthcare, and what this could potentially mean for those with chronic disease that is impacted by dental care. The next slide just shows some modeling that we did looking at estimated changes in dental procedures. And what we're seeing in our clinic anecdotally is some significant increases in endo and perio. Again, that might be expected because those are often emergent situations. And I think Marko may be speaking to that. There is also some thought that there may be some stress-induced need because of the pandemic for some endo procedures. And we're continuing to investigate this, and we're working not only with our own data, but with the Big Mouth Data Consortium, which is an academic consortium, and also continuing to look into what this might mean for the economics of dental practice, as well as what it might mean for the health of the population. Thank you.
Thank you so much, Jane. That was fascinating. And Marko, the HPI has done really remarkable work in this sphere for some time now, since the beginning of the pandemic. So looking forward to hearing what you have learned as well, and especially what's been most surprising to you. Just get those slides teed up for you, Marko.
And as you said, I think as a researcher, one of the things that I guess is exciting is not the right word, but maybe rewarding about this is that you'll see there, we were able really early in the pandemic to set up like a surveillance system. So we're tracking somewhere around 3,000 dental practices across the US, nationally representative sample. And you see here, we have data every 2 weeks that we collect. And we've been tracking things like, is your office open or closed? And how many patients are you seeing? And as you'll see in a sec, a whole bunch of like questions of the week. We've also been tracking infection rates among dentists. And we recently expanded a collaboration with the Hygienist Association to do that as well for hygienists. So I think what I've been most proud of with my team is just that we've been able to turn around information in just a completely different way over this pandemic. But let me share some kind of insights and I guess surprises. So what you're seeing on the screen is patient volume in dental offices measured as a percent of pre-pandemic levels. And so you see here as dentistry basically closed for everything but emergency care in late March and early April, complete fall off of patient volume. And then you see that kind of pretty steady rebound. And then you see this new steady state around 80% of pre-COVID levels. So I guess one of the things I frankly was surprised with was how quickly the sector kind of reopened with, again, new infection control protocols and all that. But the rebound in patient volume, I thought would take much, much longer. And again, good thing or bad thing is a different story, but clearly here, and our public polling confirms this when we ask patients, I mean, the public largely views dentistry still as safe through the pandemic. And we know the CDC and ADA worked hard to have new infection control protocols and PPE standards, et cetera, that our research shows have been very widely adopted. So anyway, we're back to not 100% of pre-pandemic levels, but roughly 80, 3/4 to 80%. That's the blue line. Now, what we also show, another insight, is if you look at the orange circles, this is patient volume in public health settings. So FQHCs, community clinics, et cetera, non-private practice. And you see there that patient volume is lagging consistently. And I think this hints at this equity angle that we've seen front and center that this pandemic has shown in healthcare, right? It's the vulnerable groups and low income, ethnic minorities, those vulnerable groups that are being hit hardest on the healthcare side. And we're seeing that in dentistry too, right? It's the private practices that have rebounded quickest and the public health settings that are rebounding much slower. So that's one of the key insights. But anyway, if you go to the next slide, I just have a few things on another interesting thing that's come up is the pandemic seems to be having impacts on people's oral health, maybe in ways we wouldn't have expected. What you're seeing on the screen is these are dentist reported data. So we asked dentists, are you seeing any trends or changes in the prevalence of these conditions in your patient base? This is not a random sample of households, but it's from providers. It gives us some insights. And you see for all these kind of stress-related conditions, right? Grinding your teeth, chipped teeth, etc., jaw pain, TMD. You see a considerable spike from the provider perspective on the prevalence of these conditions. So I think it's interesting that the pandemic, as stress levels are higher, right? And that's showing up with oral health, not necessarily pathology, but certainly these issues related to kind of grinding your teeth and that. So that's important to see if there's a follow-on effect. Does this essentially increase demand for dental care downstream? We're not sure. And if you go to the next slide, and I'll end with these couple ones, just because, we've gotten great news with vaccine development and thankfully rollout is starting. One of the things we wanted to track was is the dental setting a feasible touch point for the population to be vaccinated? And so we asked two questions, right? This one here is the dentist viewpoint. And we're asking dentists, and I'm paraphrasing here, would you be willing to vaccinate patients in your office? And again, the top bar is those dentists in the private sector, and then the second bar below is dentists working in public health settings. And by and large, you see largely, majority, if you include the maybes on both ends, but certainly in public health settings, a significant majority of dentists saying, yeah, this makes sense and I'd be willing to do it. So my take on this is there's significant share of dentists that would be willing to do this, to administer vaccines. And then the last slide, if you go to the next one, Lisa, we asked the same question in public polling. And that's the bar, the pie on the right. We asked the patient base, the public, if you were able to get a vaccine during a routine dental appointment, would you be interested in doing this? And you see 60% of patients saying yes and 40% saying no. As a control, we asked the same thing on the left about flu shots, and you get roughly the same numbers. So, there seems to be a majority of willingness of the population to receive vaccines in dental offices. That's not to say, this is happening or will happen. There's obviously scope of practice issues. As far as I know, there's only 3 states currently that allow dentists to administer vaccines. There's about 20 states with, I guess, regulatory changes in play that would allow dentists to administer COVID vaccines, roughly, but that changes every week. But anyway, something we can talk about with the panel is this, so that's my other, I guess, closing insight. Is this an opportunity for oral healthcare providers to kind of rethink or revisit their role in the primary care system, right? And here's one potential, I guess, extension of what they do. But again, it's a question. But the data show that both on the provider and public side, this is probably feasible. So that I'll end there and look forward to hearing what the rest of the panel has to say.
Thank you, Marko. Ateev, you've done some fantastic research looking at not just the dental response in terms of patient volume and demand, but of course also the overall health system response.
Right. Well, thanks everyone, and look forward to the panel. Where we've been trying to add this is maybe somewhat similar to what Marko's doing, but now looking at medical practices. We've been tracking data using scheduling software from roughly around 100,000 providers in the US across a range for both, these are medical practices, but specialties from primary care to subspecialty care, and trying to understand how they have responded to the pandemic and what patient volume. So Lisa, if you go to the next slide, we can kind of show you some of those numbers. These are data from February all the way through October. I just recently looked at the data through last week also, so I'll comment on those, though I don't have them on the graph here. What we show here is a percentage decline from this baseline week, which we sort of chose somewhat arbitrarily, March 1st, before the pandemic. And then we show the decline in visits from there. So one thing to highlight is that there was this, as we all experienced, tremendous decline in the number of visits, a 60% decline through late March and early April. And so it's something that I had never seen in clinical practice, such a substantial change in care. I should highlight that these are total visits in person plus telemedicine. Though it's interesting to compare that to Marko's numbers and to note that dental practices had an even greater decline than what we're seeing here among medical practices. Similar to Marko, one of the things I found somewhat surprising was how quickly things have rebounded. And that as we get at first a very rapid rebound and then sort of plateauing as we get into June, July, and August. And then in our most recent numbers, even through last week, we see that the number of visits per week has actually rebounded fully and actually somewhat a little bit higher. Last week, it was 4% above baseline in terms of weeks. So in terms of total volume. So I think that's another surprising finding, even as the pandemic has raged and all parts of our nation have been really impacted in the last month or so. In terms of total visit volume, I was surprised that we haven't seen a substantial decline. If you go to the next slide, Lisa, so obviously telemedicine has played a major role here. So what I'm showing you in that turquoise line is the same line I showed you previously, but now in orange, I've added the line for the decline in in-person visits. So that the gap between them represents the telemedicine visits. So out of essentially nowhere, we've seen a substantial increase in the use of telemedicine among these medical practices. But it's also important to emphasize from here that that has only played a relatively modest role in overall care. And most of the rebound that we have observed has been a growth, a reemergence in in-person visits. And if somewhat surprising to another surprising thing for me is that even as the pandemic has raged, we generally have found that the use of telemedicine among medical practices has slowly declined over time. So that it only represents about 8%, 7 to 8% of all visits. The vast majority of those are in person. One other thing that I do want to highlight that I think is really critical for medical practices, but also for dental practices, is something I showed on the prior slide, was this: there is this cumulative decline in total visits. And so what is going to happen here is a major policy and clinical question is that all this deferred care, is it pent up demand? And as soon, hopefully soon, when we have, quote, return to normal, are those visits going to come back? Or are those visits, visits that are, completely deferred and they'll never come back? And that has major implications for all of us as we think about the workforce. The last slide that Lisa's going to add, if you could go to, is something I wanted to highlight, that I've shown you overall trends in medical practice. If we focus in on just that early period where there was the substantial decline in visits, I've now broken this down by specialty. So each of these dots is a different specialty or clinical area. The size of the dot is just the volume of providers. So the biggest circle there is primary care, in the middle. On the x-axis is the percentage of total visits delivered by telemedicine just in that early COVID period. And on the y-axis is the percentage decline from baseline to the COVID period. So just to kind of take an example, among psychiatrists, 55% of the visits that they were providing were via telemedicine, and they had a relatively modest decline in visits, about 17, 18%. On the other extreme, if we go to our ophthalmology colleagues, they had relatively few visits that were provided by telemedicine and a much greater decline. And I show this graph both just highlight the heterogeneity here, but also to think about dental practice, where like ophthalmologists or orthopedic surgeons or ENTs, equipment is obviously critical. And so the ability to really embrace telemedicine is much more limited. And therefore, I think the patterns of care that Marko was describing are more echoed among the surgical subspecialties as opposed to our behavioral health colleagues. So I'll stop there and pass the baton to Russ.
Thank you so much, Ateev. And then lastly, Dr. Russ Phillips.
Thanks so much, Lisa. So I was going to talk briefly about the impact of COVID-19 on primary care and what surprised me. If I could have the next slide. The first is really what the cost of the pandemic has been to primary care. And we did a national study where we looked at the impact on practice revenue in March through June, and noted that that primary care practices lost about $15 billion in revenue. Of course, this was a challenge to all practices, but primary care, which often is barely break even, just hasn't had the reserves to really sustain that kind of loss. It was due to the decreased visits that Ateev just referred to, as well as lower reimbursement for telemedicine, which certainly has varied from state to state, but generally there's been lower reimbursement. We did a study in Massachusetts that was led by Zuri Song in the Department of Healthcare Policy here at the medical school. And we saw that across Massachusetts, this loss in revenue has led to practice closures, or at least concerns about practice closures, with up to 25% of practices in Massachusetts being threatened by closure or sale to larger organizations. And the implications are actually two. One is, to the extent that practices close, it decreases access to our patients. And many of the practices that were threatened were those in underserved or rural areas. And then the other implication is that if practices are sold to larger organizations, then care itself becomes more expensive across the state. And there's been a large ongoing state initiative to actually reduce costs or control costs of care. If I could have the next slide, please. If anything, though, what's been really surprising is the silver lining that has been, that we've seen in the context of the pandemic. The first is one that Ateev just referred to, and that's really the expanded use of technology. It's been really dramatic how rapidly primary care has been able to shift to telemedicine. As he referred to, across the country, 50% of visits were provided by telemedicine. In my own practice, that number was closer to 80%. And essentially, we shifted over a weekend to using telemedicine as our primary way to deliver care. In addition, we expanded use of home monitoring, and again, in my own practice, we've asked patients to get blood pressure monitors so that they can let us know their blood pressure when we do a telemedicine visit. Of course, they often have a scale at home, so they'll weigh themselves. And we've used pulse oximeters to monitor patients who have COVID or where we're concerned about COVID. In addition, there's been a greater recognition of the importance of systems thinking across primary care. This is a strength of primary care, but another pivot that we've seen primary care make is to creation of specialized respiratory units. And really those have been designed to assure follow-up and improve the care of patients with COVID or COVID-like symptoms. Often these are coupled with technology, so we're reaching out to patients through texting to monitor patients' symptoms. We're using home monitoring to monitor oxygen saturation, and then making appropriate referrals to the emergency room when necessary. A third area is really the attention to social justice and the impact of social determinants of health on treatment and outcomes, where it's been absolutely clear that patients of color are less likely to be tested for COVID. They're more likely to suffer the ill effects, both in terms of mortality and the impact on their livelihood. It's been something that certainly has been highlighted by the Black Lives Movement, so that practices were tuned to it. But if anything, it's increased the use and the impact of community health workers and the importance of community health workers within practices. And next slide, Lisa. It's also highlighted the need for integration of behavioral health for patients with anxiety, depression, and substance use. All of these have gone up, I think, and similar to in dentistry, where we've seen stress-related illness go up. Certainly, we've seen increases in anxiety and depression. Practices such as my own that have integrated social work are able to refer our patients, but for practices who don't have those linkages, it's been a real strain on primary care. We've also seen a critical need to engage patients in the care and the functions of a practice. This was a movement that's been going on, but certainly as we've thought about how we respond to patients' concerns about being exposed to infection and real risks as they come into our offices, we've been able to convert rapidly to telemedicine and create specialized units that in some ways create separation between patients who have COVID or COVID-like symptoms from the rest of our patients that need to be seen on an urgent basis. And then finally, I think an impact that COVID will have is actually to accelerate the movement towards global payment or capitation, which I think will address practice resilience and survival in the context of this pandemic, but also in terms of other stresses. There's been a gradual movement, especially in large systems, to global payment. In Massachusetts, there's actually now a movement for smaller practices as well. And the Center for Primary Care, some of the work that we've done has really been focused on advocacy, where we've advocated both to support practices that are having difficulty surviving within the context of the pandemic, but also to help move practices towards capitation, which we think will expand the capacity of practice to innovate, will make it less critical exactly what something like telemedicine is paid for, because we'd be paid in different ways, and would enhance practice resilience. I think I'll stop there. Thanks so much, Lisa.
Thanks, everyone. Those were great slides. Looking forward to kicking off this conversation. So I think there are some really interesting parallels and also some striking differences in terms of primary care, other perhaps ambulatory procedural services, and dentistry. But one thing I'm curious to think about from both perspectives is, of these many changes we've seen in the context of the pandemic, which do you think will stick around and which are going to be rolled back as soon as it's feasible, especially in the context of the rebound we're seeing now? So Marko, given what you've seen from practicing dentists, what changes do you think will be permanent and maybe the way we practice in perpetuity, and which will be a historical artifact?
Honestly, I don't think much will change. Like Ateev was saying, like we saw a spike, for example, in teledentistry, and the minute patients kind of offices opened up, that went right back to where it was pre-pandemic, right? I don't know, things like increased collaboration with primary care practices. Again, there's no indicators we're picking up that shows that's going to ramp up. So honestly, I don't think I would have predicted this will be a transformative shock to dentistry. That's one of the things back in March and April I was certainly talking about. The data just don't support that. Largely, things are going back to normal. The only thing that this may, I think, accelerate is practice consolidation. So that's a trend where dentistry is really lagging the rest of healthcare. But I think because of potential retirement exits that we're seeing now, we may see some of the larger, more capitalized groups in a position to go on a buying spree. That's the only thing I would predict. But I don't think we're going to see much large-scale practice modality change.
Thanks, Marko. Appreciate your, as always, realpolitik view of this. And Ateev, actually, same question for you in terms of sort of seeing a similar pattern, at least in telemedicine usage in the primary care context.
No, so there I do think that in contrast to dentistry, we will see long-term changes. You know, one of the ideas, and I think this is echoed throughout our lives, is that the pandemic has accelerated changes that were already happening. And so I think in this context with telemedicine use, we'll see similarly that we'll have kind of accelerated changes that would have happened over a decade now into a couple months. But I do want to emphasize there's a lot of uncertainty about that, Lisa. And how much of an acceleration there will be is really unclear. And I think that's very much a policy question. How much do our major payers, Medicare, our private insurers, and Medicaid, do they reimburse for all forms of telemedicine as they currently are, or do they limit it in some way? And as Russ alluded to, how much are they going to pay relative to an in-person visit? Is it going to be equal, which a lot of telemedicine advocates, so they, you know, there's a bunch of states that have passed telemedicine parity laws, or is it going to be less than in-person visits? And there's very active debate on both of those issues, both within the Congress, state legislatures, as well as private insurers in terms of what decisions they will make on those issues. And that's really going to drive, is this going to be a modest increase in telemedicine use or really transformative? The only other thing I would add, Lisa, is that, and this is a little bit alluded to also in Russ's slides, is that a lot of the focus has been on video and telephone visits, audio only. A telephone call has been relabeled as an audio only telemedicine visit during the pandemic, versus I think a lot more innovative delivery options, such as telemonitoring programs, where people are using continuous glucose monitors or apps or scales that connect to the internet. All these very innovative ideas on how to manage chronic illness. Those, I think, are really where the potential is. But I do fear that there's also an element of this, which is we're so focused on the short-term issue, should we pay for video visits? And we're not thinking about the bigger picture issue, which is how do we really transform how we provide care from a visit-based model to this kind of monitoring kind of framework.
Really interesting. Thanks, Ateev. And Russ, you've actually mentioned that you've now transitioned fully back to telemedicine visits in the context of the second wave of the pandemic. So I'm curious from your perspective as both a researcher and a provider, do you sort of see limitations in your ability to practice through that modality, or do you foresee other technological innovations that'll make that easier for you and for your patients?
Yeah, well, just to say that I agree with Ateev that I think that the pandemic is accelerating a change that we were seeing already towards telemedicine. I actually think that telemedicine is here to stay for many types of visits, like counseling visits. You know, can be very effective. You know, we've seen that in social workers and psychiatry, where there's been a complete transition to telemedicine, and I suspect that is probably here to stay. There's no question that there's patient demand and that it offers more convenience. So, you know, I saw 2 patients by video who lived, 60 miles away, and they really appreciated being able to access care without needing to travel into Boston. There's no question that at times the physical exam is important, but it's not necessarily, critically important every visit. So, I would say in 80% of my telemedicine visits, there's no need for specific follow-up. And if I need labs, I can get those done locally. So I feel I can do very well through telemedicine visits. I think it's probably going to end up being, 20%, 25% of primary care. I do think the issue of payment is important, but I also think that the pandemic is going to accelerate movement towards capitation. So the exact rates by which telemedicine is paid versus something else will be less critical if we're actually paid in a global payment kind of way for the care that we provide. That'll really accelerate the move towards value-based services. And there's no question in my mind that telemedicine is really a value-based service.
Lisa, if I could address one other point to build off Russ's comments, because I don't know if people are focused so much on this, which is a lot of the conversation and debate has been about existing providers like Russ and his primary care practice, or big health systems on the medical side, and what their role of telemedicine is. And I think relatively under-recognized is the hundreds and hundreds of startups that are telemedicine focused companies, from urgent care, and I think many of you on the call are familiar with Teladoc, American Well, Doctors on Demand, but also companies that are very focused on specific clinical areas: diabetes care, virtual endocrinologists, virtual psychiatrists. We have many companies that are focused on just very specific, for example, menopause treatment. And those companies are out there. They are poised, have already had substantial growth during the pandemic. And so I think that's another aspect of this that I think there's a lot of uncertainty as we move forward, that when we see the growth of telemedicine afterwards, how much of that is going to be the Russ Phillips of the world in primary care versus how much of that is going to be, a virtual urgent care provider, and that it's going to lead to somewhat of a clash.
Yeah, almost a question of whether this is a tool for the use of a pre-existing system or whether this could even constitute a disruptive innovation on the economic side. Jane, unlike a lot of other practices like Marko shared, the dental schools continue to be able to use teledentistry at rates higher than most private practices are, at least right now. Would you be able to speak a little bit to sort of what it's being used for in that setting and any adaptations the schools made to facilitate that?
Primarily, teledentistry right now serves as a triaging function and supporting on-call. It was incredibly helpful to us back in the beginning of the pandemic when we were not able to see patients in person at the dental center. We are continuing to use that as a tool right now. I think another way we're using technology is with pre-screenings of our patients, adding that sort of data into our database and having the patients become familiar with filling out forms online, and for us to collect more information about the patient and the patient's individual circumstances with all of the COVID information that we're collecting. And I think that's beginning to set us up by taking some baby steps, if you will, towards an integrated health record that might be of use to us if we're going to start thinking about vaccinating in the dental office. And the state of Massachusetts, actually, the Mass Dental Society has come forward saying that dentists should be part of the vaccination team as we go forward here when vaccines are ready. So I think that teledentistry is something that is here to stay. I think it will not permeate the field as much as other specialties of medicine, but I do think that it's here to stay and will serve primarily as a triaging role, and we'll be able to use some of those services to help integrate information about the patient.
Great. And I'm getting a lot of questions in the chat thinking about the potential for something like telemedicine in general, or sort of more remote care, to be a different kind of integration of oral health and medical care. When we talk about integration, we're so often thinking about co-location or other sort of in-person interactions. So Marko, going back to your idea that I actually agree with, that I think we're going to see very limited change, at least in the private practice setting of dentistry, but do you see any potential for some innovation to be used, at least in some of these health center or community-facing organizations that are delivering a different kind of oral health care, or might be more invested in leveraging some of these tools?
So yes is the short answer to that. There's obviously potential. I don't think COVID has done anything big on the production side or on the technology side that's new, right? I think we've had these capabilities for better integration. I don't necessarily think it's a technological issue, et cetera. It's more of a will. And I don't want to get esoteric here. I mean, look, I'm an economist, but I really want to echo what Ateev raised. Like, to me, the payment model is in the way. And that's how I view this, right? It's fee for service based in dentistry, I'm talking, right? But largely in medicine too. And until you break out of that and start rewarding provider side a little bit differently, right? I don't think you're going to see any big takeoff. So to me, like, if we were to reward health systems or providers for getting diabetics screened for oral diseases, right? That all of a sudden, boom, sets off a chain of events where we need to actually bridge that gap. I need, maybe Ateev and Russ need to know where to send people who are diabetics and they've asked them, they haven't had a dental screening in 3 years. Like, what do you do then? How quick is that handoff? How easy is it to get the information into that health record that then lets you get an update on the status of their gums or the inflammation in their mouth, etc. So I guess I'm coming back to this issue of, I really liked what Ateev said, like, if Medicaid and Medicare were to continue on this value-based payment reform slash, moving away from fee for service, that frankly, I think is going to happen regardless of who's in charge, right? Both sides of the aisle like this for different reasons. But until we see something dramatic there, we're going to be, I agree, nibbling around the edges, and we'll see the early adopters push this, but it won't be large scale. So I guess my point is, I would argue that a big thing we need to work on is payment reform to kind of incentivize some of this integration.
One thing I might add to that conversation is a little bit, so what Marko said makes a lot of sense to me in his earlier comment that likely in the delivery of dentistry, there's unlikely to be any substantive changes, at least in the short term. But I do also want to say beyond the payment issues, there's also a technology component of this, which I think the pandemic might have accelerated. So to turn back to medical practice, if you ask the average obstetrician, can you do a prenatal appointment via telemedicine? They're like, no, I got to check the baby and see. But now they're like, oh, maybe I'll send patients home with a fetal heart monitor, something they would have never done before the pandemic. And all of a sudden a telemedicine option is available. Ophthalmologists are saying, of course I can't do a telemedicine visit. But now we've had the introduction of a number of increasingly cheaper retinal scans. So a patient will just simply walk up, put their chin down in there, and automatically have a picture of their retina taken that can be sent electronically to an ophthalmologist. And all of a sudden they can do management of diabetes, for example, to build off of Marko's example. Is there an opportunity, not next year, but in the coming years, for those sorts of technology options to be introduced into dentistry that would all of a sudden make this facilitate a teledentistry growing, so that when Russ has the patient with diabetes in his practice, instead of referring them to the dentist, is there something that could be done in the practice so that images that are necessary for the dentist so that they don't even have to physically go to the dentist's office? Possibly, I don't know, but I just wanted to highlight there is that momentum in that direction.
Yeah, I agree. I think that we have an interesting confluence of events right now. I think that we will see change. I think it's too soon for us to see any kind of major change. I think the economic hits that a lot of the practices have taken are going to have providers thinking differently about the types of payment they want to accept and whether an ACO or alternative payment model is something that they want. David Blumenthal wrote recently in a sounding board piece in the New England Journal of Medicine. He asked whether healthcare is an essential national resource that warrants financial security. I mean, do we want to have our frontline workers potentially at risk for economic loss like we've seen right now? we don't know what kind of pent-up demand we have right now for healthcare. Looking at the slides that you just showed us, there was a huge drop-off in visits. And yes, we're now back at 70, 80% of visit volume, but there still have to be a lot of patients out there who have not been seen. And we don't know yet what the progression of disease is like for those patients. So I think there's potentially a tsunami of demand that may still hit us. And there are still a lot of providers who are hurting that are going, and those two forces are going to force us to make some kind of change down the road. And I think conversations like these and getting people thinking and talking about what are the possibilities and how can we do things differently, whether it's how we deliver the care or how we pay for the care or even how we educate and train our providers. These are really important conversations. And I think in a couple of years, we'll see a very different system. I think the pace of change is going to be accelerated by this. I'm still hopeful that we'll see some change that will help the people who have been disenfranchised by job loss and insurance loss right now, because I'm very concerned about widening disparities as a result of all of this.
I think everyone is speaking the language of value-based payment, and to answer one of the Q&As, yes, that is the current euphemism for what was previously known as capitation. So we don't need to necessarily mince words. I think all of us agree that this is probably a necessary move in medicine and dentistry. But Russ, I think you win the prize for bringing it up earliest. So I'll go back to you with this. One of the things we're talking about is that this value-based payment reform, at least on the primary care side, could essentially be a pain point for a lot of primary care providers to offer a whole scope of different services. And at least in this context, we're thinking about asking them to use intraoral cameras to look at people's mouths, to ensure follow-up via telemedicine or teledentistry with a number of additional specialists. Do you see any additional resources needed or to be leveraged in the primary care setting that would make these opportunities to actually have primary care providers feel like all of this is sustainable and it's not just the entire health of the patient resting on their shoulders?
There needs to be more investment in primary care, and there's no question about that. In this country, only about 5% of the total medical spend goes towards primary care. And if you look at Medicare patients, it's even less than that. It's like 2.5%. And it's not sufficient to deliver the kinds of services that we need in primary care. So we need to move not only to capitation, but we need to move to increased investment in primary care, which I also think has the opportunity to decrease healthcare costs in other areas. And we've done research on this in Rhode Island, where they doubled investment in primary care. They also put caps on hospitalization expenses. But by doing that, we're actually able to reduce total medical spend at the same time they're doubling investment in primary care. I think as we think about capitation, payers are going to need to think about paying for services. So if we're talking about integrating behavioral health to primary care, we can't do that at the same level of capitation as a practice that's not providing that service. So it makes sense to me that there'd be an extra payment, for that. Ideally, we would be joining together with dentistry and having a capitation that covers both. Because I was actually going to say, as we think about telemedicine, two of the services that we provide in primary care, which is measuring blood pressure and giving vaccines, could be done by our dental colleagues. And that would actually save visits to primary care. It would allow us to do more telemedicine, because those are two of the physical things that need to be done, which often can be done when patients are in the office of dental providers. And so there really are opportunities, I think, for integration as we think about value-based care that would actually cover both dental care as well as the rest of healthcare.
Great point. Thank you.
Can I chime in?
Of course, please, a free-flowing conversation.
I guess a question back to maybe to Russ and Ateev to start. So on the payer side, so we talked on the delivery side. On the payer side, there's also this siloing of dentistry, right? That it's financed, at least in the private side, among standalone dental insurance, right? And a lot of people argue, I'm one of them too, that also is an additional wedge, and it diminishes the incentives because, okay, even if I believe that diabetics do better and have reduced healthcare costs if they get their dental screenings, et cetera, those savings, the costs accrue to the dental side, some of the and then the dental's not covered under the medical part, whatever. It's another set of complications. The downside is I feel the dental community fears the minute dentistry would be paid for under larger medical bundles. Now you get competition, right? And where does the dentistry fit relative to behavioral health, the transportation services, and all this other stuff, which is valid. But can you, on the clinical side, can you give like either a reality check, like if dentistry were covered under core healthcare plans, medical plans, would this in practice, let's say, make it easier for you to refer more patients into dental? Or you're like, you know what, the financing side, I don't really think of. Like, what's the reality check on this? Is it an issue?
If I could just answer that quickly, I think it's a real limit to integration of services. You know, it's very difficult to have services within our practice if, let's say, we want to integrate a dental care into primary care, when dental care is not fully covered in the way that primary care is for patients. So it really keeps us, I think, from sort of integrating services into the future. We also have patients that just I can't get access to care for, who have, you know, their healthcare coverage but don't have dental coverage, and that's like 20 to 30% of my patients, depending on you know, sort of the depending on the providers. You know, for our residents, that may even be more the case. I work in a teaching practice, so it's clearly a barrier, you know, to integration, and it's a barrier to high value care. I also, though, would stress that it's not just a matter of cost, but it's also a matter of quality of life. You know, we know that primary care saves lives, but a lot of the things that we do in primary care are not going to save costs. They're going to keep people living longer, and they are going to lead to a better quality of life. And I would argue that dental care does the same thing. And if we reduce everything to costs, then we're not paying attention to what matters most to patients, which often is quality of life. And that should be something that brings dentistry and primary care together, as we're both really focused on improving patients' quality of life.
Beautifully stated, Russ.
Very quickly add that the ideas that you presented, Marko, I think are really important, but they are not unique to dentistry. We've had behavioral health carve-outs for many, many years. We've also had carved out all the pharmaceuticals with pharmaceutical benefit managers, or PBMs. And I think that if we look nationally across the landscape, there was an acceleration to having more and more of these carve-outs. And I think we're seeing the opposite trend now, where, and what drives that, I think, is to some of the issues that you've described and Russ described, which is integration. That it's very hard, you know, when you think about drug costs, you know that some of the benefits are going to come on the medical side, but if you think about your silo, you're not going to look at those spillovers. And so I think you are seeing increasingly a reversal of that trend to having one more consolidated insurer. Also, as employers almost universally are now moving towards having dental benefits, I think that's going to be a thing, because it also addresses on the administrative side. As an employer, you're like, got to get my pharmaceutical BPM and my dental, and it's very complicated. It's much easier to go to a single site. And then lastly, on the patient side, it's frustrating during November when you have to go and choose all these different sites. It's much easier to have a single one. And so I think all of those are going to move forward into more consolidation, where dental benefits will be part of all the other benefits that folks have. What that implies and what will happen to dental practices specifically, that's hard to know. That's going to be more negotiations. It's going to add administrative burden, obviously, for dental practices, because now you'll have a much larger number of insurers that you'll have contracts with, and how those payment rates will vary is unclear to me.
Well said. Looking specifically at the current period we're in, I think we're in a very difficult situation for, I think, everybody, where we're experiencing a second surge that is frankly catastrophic. We're not seeing the same practice changes that we saw during the earlier part of the pandemic in spite of that. And yet we're also on the dawn of vaccination. So I'm curious, both on the medical and the primary care side, what do you make of this pattern of not seeing any sort of restriction in ambulatory care currently? Is that because we've learned enough about how to prevent COVID in those settings, or are we looking at economic imperatives rather than medical ones?
I mean, on our end, I can just maybe speak, because we have pretty good data on this, right? So we've tracked the infection rate among dentists, And the latest data we published showed 0.9%, right? So less than 1% have been diagnosed with COVID, which is very low when you look at comparisons to other types of healthcare workers. But again, it's not necessarily comparable, right? Like healthcare workers are seeing people that are very sick and dentistry is not. But largely the use of the new guidelines, the data now show that there isn't basically, well, as far as I know, there isn't a documented case of transmission in a dental office. But whatever, the data are suggesting whatever we're doing is working, whether it's screening out patients that are maybe COVID positive through additional, temperature checks and all the screening ahead of time. But the public is largely saying it's safe to go back, right? So, and look, we don't know why that all is. It could be just that the sicker patients are just staying away from dentistry, right? It could be that. It could be that the new PPE guidelines are really, they're doing what they're supposed to be doing. Yeah? But the other thing I do want to look at is we've correlated like all the data from Hopkins on, local level resurgence rates with patient volume, and there's zero correlation. So I think that was at one of the heart of the questions. We're not seeing any relationship between states with big outbreaks versus small outbreaks in terms of any effect on patient foot traffic. So that again shows me that I don't think there's anything on the dentistry side, at least, that's kind of unique to what's happening on the patient or on the population outbreaks in general.
Yeah, no, I think that's true in primary care as well. Just to say, I think we have systems now where we can assure patient safety when they come into our practice. And there really are very isolated cases where patients have actually contracted an infection through the process of care. So I think we've learned something from the first surge, essentially, that we can deliver care, safely. That's not to say that it's safe to get to our office. And if you're taking public transportation, you're probably at greater risk when you're on public transportation than you are when you're actually, in the office. So there's still reason to try to limit patients coming into the office during periods of surge like we're going through right now.
I might just quickly add that I know time is tight, but really that I always worry that we've done an amazing job of reassuring the American public that it's safe to get healthcare. And on one hand, I love that. On the other hand, I'm a bit worried that we've taken it to another extreme, which is now we're doing all sorts of elective surgeries and so forth and having people do transportation. And I think a lot of that is driven by finances. Medical practices took an enormous hit and they're worried about another hit. And so if anything, I feel like we've almost gone to the other extreme. I don't want to say to the American public, oh, you should be nervous about getting care, because it's a balancing act. But I wonder on the provider side, whether in the ideal public health side, we would be really shutting down elective procedures right now. And I don't see that happening to a great deal right now in that US healthcare system.
Seems like public health messaging, including nuance, is something that is maybe lacking in the overall pandemic conversation, regardless of what part of the health system we're talking about. Well, thank you all so much for in the audience for writing fantastic questions. It's clear that I think we could keep these guys here all day. Just asking amazing and thoughtful questions, but given the brevity of our time together, I'd love to just go around, and if anyone has any closing thoughts or hopes for the future, I think we're really at the dawn of a time of optimism in America, and so I would love to hear from that, and I'll just go around the list, starting with Jane.
Oh, thanks. I'm hopeful that this is a catalytic moment where we will see major systems reform, where we'll see dentistry integrated with primary care and the rest of the health system, and that we'll see an expansion of benefits that addresses the disparities that we see right now.
Russ?
I think the big challenge that we're facing right now is actually vaccinating our population. I think there are subsets of our population, primarily persons of color, that are going to have or will, have already expressed a lot of resistance to vaccine. I think primary care practices are positioned to hopefully play a really large role in that. We've generally earned the trust of patients, but it's still going to mean reaching out proactively and having additional resources. And I was glad to see that in the bill that's before Congress now. They're talking about additional resources to actually administer vaccine. A ton has been spent on actually producing it, but actually getting it to patients is going to be really a challenge.
Ateev?
You know, the only message I would have, just to echo on Russ, is that I think to the audience and to the panelists also, that the vaccine and building the trust, so that hopefully all of us on this call will be able to get a vaccine soon, and then to, when you get the vaccine, you know, broadcast that widely on whatever social media, whatever else, because I think the American public is looking to all their healthcare providers on trust. And if they see their dentist, their primary care provider, or anybody else, they're getting the vaccine, that's going to increase and perpetuate that trust. So I just want to emphasize the role we have in public health messaging.
Mhm. Thank you.
I'm going to go totally different, put my wonk hat on. We're all researchers. I think this has shown when pushed, we can collect data and do analysis much differently, much quicker, much more efficient. And I hope we continue to do that as a research community too going forward.
Yeah.
Thank you all so much.
Thank you all. Yeah.
It's
Thanks,
been a
everyone.
delight speaking
Thanks
with all of
very
you.
much.
Thank you to the audience, and I can only hope that we have further conversations and perhaps even imagine having them in person one day in 2021.
Thank you.
Thanks,
Thank you, Lisa.
everyone.
Thank you all for attending.
Thanks very much.